Okay, now, so we've covered acidosis. Now we need to look at alkalosis. If we look at alkalosis, which is the other side, and I'll stand over here so you can see it better, but it's blue, it's polar opposite of red, and it basically, if you just look at the words, it's the opposite words of so many of the words in the column. But now in your packet, you're going to have to go towards the middle section of your packet to find alkalosis, because the beginning of the packet has a lot of acidosis. It talks about a high potassium, but now you're in alkalosis, which means all K is low. Okay, so we want you over in the alkalosis section. Causes of alkalosis should be where you are, and that's essentially where we start. Now, so if you look at alkalosis, let's go in the same order that we did before and start with the obvious. The obvious is hyperventilation is a cause for alkalosis. Why? Because CO2 is an acid. If you breathe exceptionally fast, like really, really fast, then you're going to have a situation where you're blowing off too much CO2. Who does this? A whole lot of people. So you can consider panic attack or anxiety. A mother in labor, and we're talking active labor, and she's huffing and puffing. It's coming, the baby's coming. I mean, she's panicking, really. The two go together. Okay, so panic, anxiety, the laboring mom. Here's one. Pulmonary embolism. Definitely not the same thing as pulmonary edema. Pulmonary embolism is a clot that started in your extremities, your leg or arms, and it's called a DVT, deep vein thrombosis, and it broke off and it moved to where? Your lungs. Don't forget, if you send a clot to your lungs, all of a sudden you're going to start coughing and not breathing really well. And the key is with alkalosis, most of these respiratory things happen all of a sudden. So pulmonary embolism, you're caught off guard because this clot has just landed in your lungs. And please remember what I said, which is that 100% of PEs are starting as a DVT first, okay? All right, so we have the pulmonary embolism. Then, of course, we have asthma, but notice what I wrote. It says early asthma, because in early asthma you're coughing, you're hyperventilating, there is a little bit of anxiety and panic involved. I guess you would agree. And so the patient is just not doing too good here, okay? Now if we let that patient go and we never treat them, they're going to end up on this side of the board. But initially in the early stages of asthma, they are definitely going to have some respiratory alkalosis. Here's another thing. I get a lot of patients that are on ventilators at one of the places I work, and when a patient is on a ventilator, it is more likely that the ventilator settings might be too high, and if that's true, it takes the place of the patient's breathing. So if the patient's breathing is too much, and the vent setting, in this case, is representing the breathing, so high ventilator settings is the same thing as fast breathing, right? That makes sense. Too high in vent settings is going to cause the patient to get rid of too much CO2. So that's just common sense. But then we have to look at the second reason why a patient might go into alkalosis. And it's basically anything that would be removing acid out of the body. Because if you take acid out of the body, now all you have left is alkaline. So that's kind of easy with this word. I think you would agree. This word is antacids. If you have too much Maalox, Nocamag, Mylanta, Rolaids, Tums, Protonix, Prilosec, Zantac, Pepcid, if you have too much of those medications, then you are causing your body to get rid of way too much acid. Now, if you look, there's lots of things that get rid of too much acid. Vomiting comes from the stomach. Diarrhea came from the small intestine. Vomiting comes from the stomach. When you vomit from the stomach, you are getting rid of too much hydrochloric acid. So now you're in an alkaline state. A big favorite for you on most tests, if they're smart, I would be asking the student this, is the patient who has a nasogastric tube, NG tube, not for enteral feedings, not for a tube feeding. No, that's not why this tube is in the patient's body. This tube, or NG tube, is set to suction. In fact, the word you want to remember is gastric decompression. NG tubes to suction really are there for gastric decompression. We use them with bowel obstructions. We use them with peritonitis. We use them with pancreatitis. We use them with patients who have severe abdominal emergencies or conditions in which we don't want the belly to get distended. So we literally put an NG tube down to keep suctioning the air and the fluids that are in the belly and to keep that belly from being distended and getting into trouble. So it's called an NG to suction, intermittent suction, low suction, and it is gastric decompression. Well, the problem is you've got this nasogastric tube in the belly, and what is it sucking out? It's sucking out hydrochloric acid, leaving you with an alkaline environment. So that also makes sense. Now, the liver failure, I don't want you to focus on too much. Suffice it to say, with liver failure, the patient can have a very high ammonia level and an extremely low potassium level. And so that brings me to my next issue with why a patient would go into alkalosis and what causes that to happen. And so the next issue is anything that takes potassium out of the body. If you look down here, you have something called diuretics, specifically loop diuretics and thiazide diuretics. So Lasix and furosemide, Bumex, bumetanide, your thiazide, which is hydrochlorothiazide. All of those diuretics will just pull potassium right out of the body. They're called potassium wasting diuretics. Anything taking potassium out of the body is going to set the patient up for alkalosis. And I want you to pay special attention to this area right here. If you look at the word alkalosis, I always tell my students to remember all K is low. Everything about alkalosis is a low potassium. So if you took potassium out of the body, like diuretics do, then you're literally going to have a patient that is more likely to be in alkalosis. When you think of liver failure, remember cirrhosis patients always, always, always have a low K. No ifs, and buts, or buts about it. All cirrhosis patients have a low potassium. Now there's one word on the board that I did not go over, and so I was hoping you could use your imagination and think about what you think it fits under. Most of the students would probably not know this one, but take a little time and figure it out. But really, honestly, fever. Fever is kind of weird because you see sepsis is over here in acidosis. So what exactly is fever doing on the other side? Because wouldn't it mean that the patient who is septic has a fever? Yeah, it does mean that. But before you reach the point where poison has taken over your bloodstream, we have some early signs and symptoms that don't really put us in acidosis. Fever is just a little symptom that tells us, we might be getting an infection. And just an infection in and of itself does not put you over here in acidotic state. So if you think about a fever, I try to teach you something about fevers in terms of heat, right? So think about it this way. If I'm really hot, and it's a super, super hot day, 99 times out of 100, my respiratory rate will go up. And if I'm really cold, like frostbitten, super, super cold, ideally my respiratory rate will probably go down. In fact, I don't even need that much oxygen. This is proven by the fact that patients who have arrested, they've coded or whatever, and we had to do CPR in the community to bring them back, drowning victims, they're cold. But those patients, in order to prolong and save their life, we literally will use as part of our emergency procedures hypothermia. We'll purposely make the patient cold so they require less oxygen. Now, flip the script, when you're hot, you require more oxygen. That's why if you have a feverish patient, sometimes it turns out that they will also get to the point where they need a little oxygen. Okay, so the patient with the fever is going to breathe fast. They're going to have the need for more oxygen. This faster respiratory rate is, again, right up there with blowing off too much CO2. So there you go. Now, so you get it. Now, what is the chemical for alkaline? Because again, carbon dioxide was an acid. Bicarb, HCO3, is an alkaline type of chemical. Now, what role does bicarb play? Well, the kidneys control bicarb. They'll either excrete it or retain it or neutralize it to make your pH go back to normal. So it is all about bicarb when we think about kidneys. It's all about CO2 when we think about lungs, okay? Now, in this handout, just so you know, both the acidosis side and the alkalosis side has a sheet that tells you what the causes are. In particular, if you look at the causes of alkalosis, everything I have on the board is almost there. There's some things that aren't on my board, like high altitudes. An example of that is the Colorado mountains. Another example of that is an airplane. So if a patient has a condition in which they're going to have some issues with oxygen, and you set them up into a higher altitude, they need more oxygen, so they're going to breathe faster. The higher you go up in altitude, the less oxygen it is. And so if you have a patient that has some breathing problems and some oxygen problems, they're going to have a really hard time on an airplane. An example of that is sickle cell. Sickle cell patients don't do well on the airplane. Many of them actually have some outright crises while they're in an airplane. One of my students had her first sickle cell crisis in an airplane. Thank God it was only a 2-hour flight to Disney World. She never made it. She went to the Cleveland Clinic Hospital in Florida instead. So there you go. Now, so if you look at all of this handout, it talks about a lot of what I covered. It's not just causes. If you look on the acidosis side of the packet, which is in the very beginning, and you look at the alkalosis part of the packet, you will also see that they go over the signs and symptoms, and they separate them based on respiratory and, of course, metabolic. Don't get too crazy with that. This is what you need to keep as a summary. The most important part you can keep as a summary with regards to what would I see with the patient in acidosis. And again, let me remind you, that's at the very beginning of the packet. If we're looking at what would I see in a patient that has acidosis, if you look at the respiratory handout, respiratory acidosis at the beginning of the packet, the most important thing for you to highlight is the low blood pressure. The low blood pressure is the key. And I want you to remember with the whole respiratory acidosis that the patient will definitely have a very high K. So high K, low blood pressure is always acidosis, always, okay? Now, at the bottom of that page, and I did it in a green color as well as blue, at the bottom of the page, I want you to put how in God's name do we treat respiratory acidosis. It's easy. It's a respiratory condition. Oxygen is first, nursing, action. So I have a list. Oxygen, cough and deep breathe, chest physiotherapy. The patient might need suction. You definitely want to consider CPAP or BiPAP. Maybe if it's really bad and the respiratory acidosis is just not getting any better, then we need a mechanical ventilation. All of that should go at the bottom of your respiratory acidosis page. And you can see the symptoms as they are. Now, metabolic acidosis. Metabolic acidosis, you're going to treat it completely different. It's a kidney issue, it's a bicarb issue, it's a chemical issue, it's a poison and toxin issue. How do we deal with any of those? We flush it out and take it out, right? So IV fluids would be your first nursing action with this patient, because keep in mind our potassium is high too, and we're just trying to get that potassium out of the body. So we have our IV fluids. We still have the same thing. We have a high K and a low blood pressure. You'll see that as the first and second, issue on the paper. And so to treat this, IV fluids. If it's a poison or toxin we can do anything about, antidotes, maybe Narcan, maybe whatever you need to reverse that poison. Dialysis, if we really are having a hard time, we may need to dialyze all the poison and toxins out. Certainly with the high K, dialysis sounds like a plan. Okay? All right, so that's kind of making sense to most people. Now, you do need to go all the way to alkalosis for the same type of thing, where we teach you how to treat it. Okay, so if you go to the causes of alkalosis, and you turn the page, you will see a respiratory alkalosis issue. And the number one thing to treat the respiratory alkalosis patient is going to be treat the cause. That's that simple. But what I want to bring to your attention about respiratory alkalosis is very often there is an electrolyte, not just potassium, that goes with it. It's also calcium. Very often you will have a decreased calcium for alkalosis. You already have a decreased potassium. You will often have a decreased calcium. If you look at the handout, it talks about numbness and tingling of extremities. That's related to the low calcium. If you look at the top of the handout, it says hyperreflexes. I call that brisk. That is also related to a low calcium. So this is a pretty good handout. It has a bunch of stuff already on here. I do want you to pay attention to the tachycardia, which may be part of the deal, and the seizures. I would put stars by the seizures because that generally has to do with the low calcium. So again, the causes we went over. The treatment, treat the cause, okay? Now, if you look at metabolic alkalosis, which is obviously the next page, you'll see that I literally colored the area where you have all K is low. I just kind of tried to hook y'all up with that right there. Now, for this one, when we look at the treatment for the patient and we try to figure out just what is going on, again, you would have to treat the cause, okay? Sometimes it's DKA, or not DKA, but sometimes it's as simple as some fluids and maybe electrolyte replacement because all K is low. So it just depends on what's going on with the patient with regards to that. If it is a situation where the patient is having some GI issues, some gastrointestinal issues, again, you may have to give the patient some medications to help with that, okay? Now, so hopefully you understand acidosis versus alkalosis. And next we're going to move to your favorite part, pH calculation.